Hello, my name is Shirley Chang, metric number BM23110013, and I'm going to present about ectopic pregnancy. Now let's get started with the presentation. The first question is, what is an ectopic pregnancy? So an ectopic pregnancy is a pregnancy in which the implantation occurs at a location other than the endometrial lining, and it is most commonly occurs at the fallopian tube. As the pregnancy grows, it can cause tube to rupture, and this will cause major internal bleeding and might cause maternal death. Next, we move on to the risk factors. What factors increase the risk of a woman getting ectopic pregnancy? So the first one is the woman who fall pregnant after previous ectopic pregnancy or prior fallopian tube pregnancy will have higher risk of getting ectopic pregnancy. The same goes with women who undergo previous pelvic or abdominal surgery and endometriosis. And for women who also use intrauterine contraceptive device IUCD, they will also have the risk of getting ectopic pregnancy too. But then it is not in women who conceive due to failure of oral hormonal contraception or barrier methods. And the last one is pelvic inflammatory disease. But then, all these factors listed here are not the only factors that contribute to a high risk of women getting ectopic pregnancy. There are also more to it. So next, we move on to the anatomic structure of ectopic pregnancy. In normal pregnancy, the fertilized egg should get implanted in the endometrial wall of the uterus, but for ectopic pregnancy, it gets implanted in the fallopian tube or other places apart from the uterus. The other part is interstitial portion in the isthmus, ampulla of the fallopian tube, in the fimbriated end, and also in ovary. But it can also get into the abdominal cavity, but with very low percentage of occurrence. The thing is, it can get implanted outside of the uterus is because there's damage to the tubal mucosa, which could obstruct embryo transport due to scarring. And there's also small defect in mucosa will also attract the implantation to fallopian tube caused by infection or surgical trauma. And also dysfunction of tubal smooth muscle activity will also contribute to the factors of a fertilized egg getting implanted outside of the uterus. Next, we move on to the morphology. What kind of ectopic pregnancy are there? So we have five morphology, 5 types of it here. The first one is gestational sac with a live embryo. The second one is sac with an embryo but no heart rate. The third one is sac containing a yolk sac, and the fourth one is empty gestational sac, and the fifth one is solid tubal swelling. The thing is, the potential for false positive diagnosis is higher when the sac is empty. Here we have an example of ultrasound of a gestational sac with a live embryo, where here is the uterus and here is the gestational sac with a live embryo and a yolk sac, which clearly shows that it gets implanted in places apart from the uterus. Now next, how to diagnose ectopic pregnancy. We have 3 ways here. The first one is surgery, the second one is ultrasound, and the third one is by biochemical measurements. The first one, as most ectopic pregnancy are very small and cannot be felt on palpitation, we have surgery to diagnose it. This diagnosis of ectopic pregnancy was made at surgery and then confirmed on histological examination following salpingectomy, and the surgery is conducted using laparoscopy, which the unruptured ectopic pregnancy will typically present as a well-defined swelling in the fallopian tube. And then next, we have ultrasound. Ultrasound, we have 2, which The first one is transabdominal ultrasound and the second one is transvaginal ultrasound. Therefore, transabdominal ultrasound, it is almost impossible to differentiate between interstitial ectopics and intrauterine pregnancies on abdominal scan. So that's why transvaginal ultrasound is more preferable, because it provides much clearer image of pelvic structures in comparison to transabdominal scanning, which might provide a better and clearer image. Next, we have biochemical measurements. The main biochemical measurements is through serum progesterone and the serum of human chorionic gonadotropin (HCG), where for the progesterone, if it is less than 6.5 nanogram per milliliter, it may indicate a non-viable pregnancy. But a non-viable pregnancy does not always indicate the ectopic pregnancy. So that's why further test is required. And for serum HCG, if it is below 1000 international unit per liter, it may indicate an ectopic pregnancy. And if the HCG serum is abnormally rise at slower rate, where for the normal one, it should double up in 1.4 days before the 5 weeks gestation. But if it gets slower than that, it might indicate ectopic pregnancy. So what are the treatments of ectopic pregnancy? We have surgery, methotrexate, and expectant management. So for surgery, we have laparoscopic salpingectomy, where we remove one or both the fallopian tube, and this is the procedure of it. Next, we have laparoscopic salpingectomy, where we remove the ectopic pregnancy by incision into the fallopian tube, so that the patient can keep her fallopian tube. And this is the procedure of it. For methotrexate, it has a successful percentage of 23 to 30%. It is actually a medication, folic acid analog, used to stop cells from growing, and which then ends the pregnancy. But then it requires follow-up and might cause side effects. That's why it is only offered to women with small unruptured ectopics and serum HCG level of 1,500 to 3,000 international unit per liter. For expectant management, it requires a prolonged follow-up, where it is only a observation without intervention, and the doctors will monitor progress of the ectopic pregnancy by level of the serum HCG, because the level will reflect its trophoblastic activity accurately. If the HCG level rise up, it might indicate an increased risk of rupture, and other procedures can be planned afterwards. Now, how is the reproductive function after ectopic pregnancy? The women that have ectopic pregnancy before might have risk of getting heterotropic pregnancy, where it is a rare condition when at least 2 pregnancies are present simultaneously at different implantation sites, but only one located in the uterine cavity. And the next one is persistent trophoblastic disease, where there are abnormal trophoblast cells growing inside the uterus after conception. Moving on to the last part, we have important practitioner of ectopic pregnancy, Robert Lawson-Tait, where he is a gynecological surgeon of Birmingham, and he is the first to perform salpingectomy to treat the ruptured tubal pregnancy. And after he developed salpingectomy, many women get to stay alive even after a ruptured tubal pregnancy, and the rate of maternal death is decreased. And that is all for me for this presentation today. Thank you.